Can we start, ma'am?
Yeah.
All set?
Yes, but my video is not coming. That's okay. It's not coming.
Can you hear me?
Yeah, I can hear you.
Hello? Hello?
Yeah,
Good
your
morning,
voice is
everyone.
audible. Yeah.
Yes.
Good morning, all of you.
Good
Morning.
morning. Good morning.
Morning. A very good morning to one and all present here. We welcome you to the last day of virtual PedoRare version 3.0, a virtual rapid revision summit to achieve perfection by Indian Society of Periodontics and Preventive Dentistry and hosted by KSR Institute of Dental Science and Research, Tiruchengodu, Tamil Nadu. Today, we have 5 lovely ladies. If I had said that because we're starting few minutes late because the ladies took a little time to settle down. Actually, if I had told that my friend Vinola, I would have been beaten up. But if I tell that to the president-elect, the vice president, and the lovely moderators and my assistant editor, then I'm sure I'm going to be beaten up by all of you today. This is an because I remember every time Dr. Anshula and Radhika ma'am and Parimala ma'am asking for a ladies representation. We wanted one session with the lovely ladies here and all the moderators and speakers to this wonderful session. And we have our president-elect, Dr. Radhika ma'am, and our vice president, Dr. Parimala ma'am, to moderate this session. And we have 3 lovely ladies again, speakers, Dr. Vinola, Dr. Nupur, and Dr. Anshula ma'am. Yeah, welcome all of you. And may I now request another lovely lady, my head of the department and a co-host from here, to introduce moderators for this particular session. Yeah.
Very good morning to you all, and I'm privileged to welcome the dynamic moderators of today's session. First, I'll welcome Dr. Radhika ma'am. She completed her BDS from SDM College of Dental Science and completed her MDS from Manipal College of Dental Science in 1997. She has over 40 national and international publications and contributed to the textbook of pediatric dentistry, authored by Dr. Shobha Tandon and Dr. S.J. Damley. She hosted the 13th PG National Convention of ISPPD in 2013 at Hyderabad. Currently, she is working as a professor in pediatric and preventive dentistry, Siddhartha Institute of Dental Science, Jnanavaram, Andhra Pradesh. She's very active in both academics as well as clinics and has been in practice more than 25 years. So we are very happy to have you with us, ma'am. We welcome you.
Thank you so much, Dr. Geeta. It's a wonderful opportunity for me to introduce and moderate this session of final day of rapid revision today. The topic being preventive orthodontics, and it's a great honor to introduce a soft, gentle, but very efficient lady, Dr. Vinola, who has done her MDS and BDS from Raja Muttaya.
Ma'am, one second, ma'am, 1 second. Yeah. I'll finish introducing the second model.
Oh, sorry about that.
Thank you.
Sorry.
So, no, it's okay. Thank you. So the second moderator of today's session is Dr. Parimala Kulkarni. She's a Dean and HOD at People's College of Dental Science and Research, Bhopal, Madhya Pradesh. And she has done her BDS and MDS from PMNM Dental College, Bagalkot, Karnataka. She's a clinician with exclusive pediatric dentistry practice in Bhopal and an academician of 21 years experience, mentoring both undergraduate and postgraduate students, and takes great pride in mentoring them. So she has more than 60 publications in national and international journals, and we are very happy to have you with us, ma'am. We welcome you.
Thank you, Dr. Geeta Priya ma'am. It's really nice to meet you all on this wonderful session, and congratulations to you and Dr. Sharath Ashokan for really taking efforts, pains, and making this program a successful one. And many congratulations. And hi to Vinola Doraswamy madam, and hi Nupur. Hello Radhika ma'am. I hope we are going to enjoy this session. Really, thank you so much.
Thank you.
Okay. I think now it's my turn to introduce the first speaker of the day. Sorry about that earlier thing. Yeah. It's my great pleasure to introduce Dr. Vinela. And I know her as a very soft and gentle, but very silently efficient lady who has passed her BDS and MDS from Raja Mutaya Dental College in 2005. Her main areas of interest in subject is preventive orthodontics and pediatric endodontics. She has numerous presentations to her credit, including the IDF forums as well. She is the fellow of International College of Dentists in Orthodontics in 2013, has received Distinguished Women Award from ISPPD in 2020, has numerous Best Paper Awards in 2014, 2016, 17, 19. And she has been the Best President Runner-Up 2019 from IDA State of Tamil Nadu, and also received Special Appreciation Award in 2021 from Tamil Nadu State Branch. She has 17 years of academic experience and is currently working as the head of the Department of Pediatric Preventive Dentistry in Vinayaka Mission Sankaracharya Dental College, Salem. She's a passionate general practitioner since the 17 years, and today her topic is space maintenance and management. All the best to you all, students, and Dr. Vinola for the lovely session. Looking forward to your session. Thank you so much.
Thank you, ma'am. Greetings and warm morning wishes to everyone here. At the outset, I'd like to thank the ISPPD head office for giving me an opportunity to contribute in virtual PedoRare 3.0 on space management and maintenance. The postgraduates will be completely thorough with the terminologies on space maintenance, space control or management, the space maintainer. So moving on to the objectives of space maintenance, it is to preserve the primate space, preserve the integrity of the dental arches, to preserve the normal occlusal plane, and also to aid in aesthetics and phonetics. The classifications of Raymond, Thorough, Hitchcock, Hendrickson, and Nakata will also be very familiar to you. So moving on to the indications. If the space after premature loss of deciduous teeth starts showing signs of closing, if the space of space maintainer will aid in or make future orthodontic treatment less complicated, if the need for treatment of malocclusion at a later date is not indicated, if we need to prevent the loss of arch length, when the space for the permanent tooth should be maintained for more than 2 years or longer to avoid the supra-eruption of the tooth from the opposing arch, to improve the physiology of the child's masticatory system and restore the dental health optimally. Some of the contraindications being when the tooth is near to the crest of the ridge, when there is no bone observed radiographically overlying the erupting permanent teeth, when the mesiodistal width of the underlying permanent tooth is less than that of the space present, and if the space maintainer is going to create complications for future orthodontic treatment. The prerequisites of space maintainers being to maintain the mesiodistal dimension of space, provide the opening if required, be as functional as possible in order to prevent the over-eruption of the opposing tooth. It should not interfere with the normal occlusal adjustments or functions such as mastication, speech, or deglutition. It should not interfere with the erupting teeth or restrict the normal growth and developmental process. It should not endanger the remaining adjacent teeth by imposing the excessive stresses. It should have a simple design that is easy to construct, place, easily adjustable, and at the same time cleansable, also to be durable and corrosion resistant. There are various variables that are associated with the treatment of the developing dentition that will affect the degree to which the treatment will be successful. And this is depending on the chronological, mental, and emotional age of the patient, the compliance of the clinician instructions, not only to the patient, but also by the parent, the oral habits that have the intensity, frequency, and the duration. The parental support for the treatment is very essential. We should also take into consideration the craniofacial configuration of the child, the growth, the concomitant systemic disease or the condition. The diagnosis should be accurate. The treatment should start at the appropriate time, and an appropriate treatment ought to be delivered to the child. Whenever an individual primary tooth is lost, certain implications will always be there. And when it comes to the maxillary incisors, the early loss will lead to the delayed eruption of the permanent teeth, speech impairment because of the development of certain habits. If the canines have already erupted, then the mandibular occlusion will start holding the maxillary intercanine arch width. When it comes to the mandibular incisors, ectopic eruption of the permanent incisors will be there, and then extraction of the neonatal teeth or due to trauma or caries will cause a space loss in the mandible. Ectopic eruption of the permanent lateral incisor is something very common when there's going to be a loss of canine. And in the mandibular canine, if there is a unilateral loss, there will be a shift in midline towards the affected side, and lingual collapse of the incisor segment will take place along with the increase in the deep bite. Bilateral loss will lead to the lingual inclination, distal drifting of the permanent incisors, thereby an increased overjet and overbite, which leads to an arch perimeter loss. The maxillary canine loss is less frequent, and if it is present, then a distal eruptive displacement of the permanent lateral incisor will be there, which will lead to either to crowding or blockade of the permanent canine. In the loss of first primary molar, it is dependent on the state of the eruption of the first permanent molar. In the age between 3 and 5 years, there will be a little or no space loss. Between the age of 5 and 7 years, the permanent first molar will start pushing the primary second molar forward, thereby leading to the loss of arch length, distal and lingual shifting of the anteriors. After eruption of the permanent first molar, there will be a little or minimal space loss in a class 1 or a class 2 relationship. And in the permanent molars, if it's an end-on relationship, it can probably become a class 2 relationship too. There will be a distal movement of the primary mandibular canine and a mesial drifting of the primary second molar. The loss of primary second molars, there will not be any space loss in the age group between 2 and 5 years. Again, this is dependent on the eruption of the first permanent molar. In the maxilla, we can expect a space loss of about 8 mm per quadrant due to the mesial bodily movement and the mesiolingual rotation of the tooth. Whereas in the mandible, the retroclination of the teeth anterior to the space will take place due to the 4 to 6 mm of space that is going to be lost. And also the buttressing effect of the second molar will be lost. 2 to 3 mm of space loss will be there even after the eruption of the permanent first molar. Certain determinants for selecting the appliance depends upon the patient cooperation, the integrity of the appliance, the maintenance. We should anticipate future modifications owing to the occlusal development. So we need to modify the appliance. Constructing a removable acrylic appliance will be more time consuming than that of the fixed appliance. So moving on to the factors that assess the need for space maintainer, the time elapsed since tooth loss. Maximum time will be within 6 months as mentioned by McDonnell and Avery, whereas in the maxillary arch, there will be more space loss than the mandibular arch. Whereas Clinch and Haley have stated that immediate space loss will take place within 76 hours following extraction, and maximum space loss occurred even after 6 months following extractions. Depending on the stage of development or the dental age of the child, again, the adjacent area, the available abutment, the stage of eruption of the first permanent molar before or after eruption, the loss of primary molar before or during eruption of the permanent laterals will play a vital role. When it comes to the amount of space closure, as mentioned already, first permanent molar will create a lot of it will push the primary second molar more mesially, and there will be an immediate space loss of 1.5 mm per arch side in the mandible and 1 mm in the maxilla. The direction of closure in the maxilla, by the mesial migration of the posterior teeth into the extraction site, all the spaces will be closed. Whereas in the mandible, the spaces will start closing by the distal movement of the teeth mesial to the extraction site, especially when there is going to be a space loss of greater than 2 millimeter. Generally, the teeth start erupting when 3/4 of the root is developed, but the eruption time can get altered depending on the developmental status, the bone density of the area, and the nature of the primary tooth loss. The eruption of the premolar will get delayed if the deciduous molar is going to be lost before the age of 5. And this eruption of premolar can get enhanced if the deciduous molar is going to be lost at the age of 8 and 9. As the age increases, incidence of the space closure decreases, and the eruption timing will also get altered depending on the impacted or the deviated permanent teeth that is present. For every 1 mm of bone that is covering, and if the bone is not covering, there will be an accelerated growth of about within 4 to 6 months. The arch length adequacy can be estimated by the position of the incisors, by the levy space of Nance, and the incisor liability. And the habits and the strong mentalis muscle will play a role in the oral musculature. And these are factors that need to be taken into account while planning the space maintainer. Also, for every 1 mm depth of curve of P, 1 mm of space is going to be gained. So while doing the mixed dentition analysis, when there's going to be a deep curve of P, 1 mm of space can be added to the space that is available. If the tooth is having caries or trauma, it needs to be restored as early as possible. But if not, what will happen is the malocclusions will lead to vertical dimension of occlusion loss, tongue thrusting, and mouth breathing habits. The congenital absence of permanent teeth also have to be taken into account while planning an effective space maintainer. So to plan a space maintainer, a mixed dentition analysis is very important, and I have not covered this in this presentation, but 2 factors that need to be considered are space required and space available. In the analysis, if there is going to be a discrepancy which is less than 1 to 2 millimeter per quadrant, space maintainer can be beneficial in holding the position. And if the discrepancy is greater than 2 or 3 millimeter per quadrant, a space regainer, serial extraction, or a comprehensive orthodontic treatment will be indicated. And in missing primary teeth with adequate space, a unilateral fixed appliance can be given in the primary first or the second molar when they are missing, and especially when there's going to be more than 6 months delay before the permanent teeth start to erupt. And if the molars on both the sides are lost and lateral incisors have erupted, the lingual holding arch can be given. In case of a single primary canine in the mixed dentition, it is better to extract the contralateral tooth in order to eliminate any midline change that will be there, that will probably in future lead to an arch asymmetry. If the contralateral canine is extracted, a lingual arch space maintainer is still required in order to prevent the lingual movement of the incisors. So when moving on to the fixed space maintainers, the steps in band formation are important, for which we need to do the separation of teeth, the band formation, and after the band formation, welding and soldering. To separate the teeth, a brass wire works well in young patients with thick periodontal membrane, and this can be kept in the child's mouth for about 4 to 5 days, but it can be quite painful. And for this, a 0.015 inch or a 0.020 inch soft brass wire is used. The elastic system, it provides a very gentle force over a prolonged period, and it is painless. And these separators are very patient compliable too. And rubber wedges can also be used. Band material, in order to select the band material, the thickness, the width, and the length will vary depending on the anterior tooth, the bicuspids, and for the primary molar and the permanent molar tooth. In the anterior, a thickness of 0.003, bicuspids 0.004, and primary molar 0.005, and permanent molar tooth 0.006 will be taken into account. The band material has 2 sides, the dull and the shiny side. The dull side will go next to the tooth to help the cement hold in place. And if a decementation takes place, it can be sandblasted and again re-cemented onto the tooth. The shiny side will be facing towards the buccal or the lingual sides. and this allows the food to be easily slide off. In the construction of the band, this is the armamentarium that is required, and in band formation, it can be either done directly or through preform bands or an indirect band technique. I'm going to talk on the direct formation of the band. So during the band pinching procedure, the band strips will be first contoured in the incisor gingival or in the occlusal gingival direction using the contouring plier. The ends of the strip of the band material will be welded, and then a loop will be made for the reception of the howlet band forming plier. The band should be pinched on the cuspal area and not on the groove areas, as it is very difficult to adapt a double thickness of band into the groove areas. When it comes to the differences in pinching of the upper and the lower band, upper is pulled from the palatal side, whereas the lower band will be pulled from the buccal side. The seam of the upper band will rest on the mesiolingual line angle, whereas the lower band will rest on the mesiobuccal line angle. Occlusal margins of a completely seated band should be 1 millimeter below. The gingival margin should extend 0.5 to 1 mm into the gingival sulcus. And for this, we can check clinically for the blanching and we can relieve the areas. And this can be done using a glass marking pencil too. Buccally, it should be below the level where the opposing cusp will touch the grooves, and lingually below the deepest portion of the lingual developmental groove. The distal, because of the raised position of the gingiva, it will require more trimming. Whereas in the lower first molar, the bands will need to be trimmed because of the rhombus shape of the tooth, and this will be festooned at the lingual cervical area. Once the band is formed and the impression has been made, the band has been transferred onto the impression, for which to stabilize sticky wax, L-shaped wire, stapler pins, bobby pins, green stick compound, and cyanoacrylic material can be utilized. Once the band is ready, it needs to be cemented, and for which earlier it was recommended to use either zinc phosphate or a polycarboxylate cement. Later on, bonding of GIC with metal surface was found to have better results, but over a period of time, resin modified glass ionomer cement scored higher than that of the conventional GIC or that of the composite materials. What are the reasons for an improper fit of band or the wire? One may be because the band was improperly seated on the impression, or an improper fitting of the band on the teeth itself, a distorted impression, and then the band mobility during the pour up if the sticky wax is not used or the band is not stabilized properly, the inaccurate wire bending, a distortion during the appliance removal, a tight contact during the placement, and if there are going to be unwanted pushing forces during the appliance trial or fitting. And finally, the poor cementing procedure. Once the band is all ready, it needs to be finished and polished, for which, for the final luster, chauffeur points or wheels can be used. Greenstone can be used to contour the soldered joint with the band and rubber wheels to reduce the surface roughness, or a gold rouge or a rag wheel can be used for final polishing. Moving on to the space maintainers. The most common space maintainer is the band and loop, unilateral, fixed, non-functional, and passive. And it can be used when single tooth is missing in the posterior segment, but can also be used in bilateral posterior tooth loss. The advantages and disadvantages are mentioned, and you can read from the textbook. Design of the wire loop. For this band and loop space maintainer, the loop should be made from the 19 gauge wire or 0.036 mm wire, and the loop can be made with a 3-prong number 139 plier. The loop should be parallel to the ridge 1 mm of the gingival tissue, close approximation to the ridge without the soft tissue impingement, and it should rest against the adjacent tooth at contact area. At the contact point, it can rest, or at the distal cervical surface, or gingival to the contact also it can rest. Middle third on the band, the free ends will be resting as said by Pinkham. And the mesio-distal dimension will be maintained accordingly, and the buccolingual dimension can roughly be about 8 mm. These are the various modifications of band and loop space maintainer. So moving on to one of them is a mains appliance, which is modified in such a way that it does not interfere with the eruption of the permanent successor. And mains appliance is indicated when the abutment tooth is rotated, when the permanent tooth is almost erupting, and when the loop is going to be a restriction for the eruption of the permanent tooth. NIMS modification is one of the modifications of band and loop space maintainer when there is a long-standing loss of primary first molar. What happens is that primary canine will occlude with the first primary molar of the opposite arch. With the mesial marginal ridge of the primary first molar will start almost touching the ridge in the space that is created by the loss of the tooth. In such a case, the appliance loop should be modified in such a way, one arm should be removed in order to create space so that proper occlusion will be allowed. Next, space maintainer. The modification is otherwise known as nickel appliance or the tube and loop space maintainer, where you can see the bands are bonded along with the buccal tube in both the primary first molar and the permanent first molar. And then the band, after the band pinching, a V-shaped wire, which is bent with the helix, will be there with two distance measurements. These free ends of the wire will move on into the buccal tubes, and then the final tube and loop space maintainer will be ready. The fiber reinforced composite resin space maintainer, it is a biocompatible aesthetic material that is made from high strength polyethylene fiber. You have a thin layer of composite that will be applied onto the buccal surfaces of the abutment teeth, and the required length will be placed using this composite. When it comes to the fabrication of a single appointment preform space maintainer, this will consist of two units. One is a male unit and a female unit. The wire loop can be cut so that the mesiodistal space requirement will be determined and adjusted. Once the wire from the loop are placed in the tubes, then the loop and the tubes will be crimped together. Moving on to the size space maintainer. It is an adjustable space maintainer. This has one main structure, two substructures, and 3 screws. You can see that the main structure will be here, and you have the horizontal component, and then you have the vertical component. So this will have 3 screws. Screw 1, which will be horizontal with adaptation. Screw 2 will have a vertical adaptation, and screw 3 can change the mesiodistal length of the size space maintainer. The advantages of this space maintainer being high patient acceptability and cost effectiveness, easily adjustable, thus allowing appropriate for the growing jaw, can be autoclaved and sterilized, and it's very simple to create too. The functional band and loop space maintainers has an acrylic thing which is along with the general space maintainer, and this aids in mastication. It prevents supra-eruption of the opposing tooth. There's a distribution of the occlusal forces on the pontic, and hence less chance of the loop distortion or slippage and impingement in the gingiva. This prevents the development of the abnormal tongue movements too. Moving on to the innovative 3-dimensional band and loop space maintainer. It is precise, quick, and easy. The development and perfection of a 3D printing model allows accuracy. It is printed as one unit, minimizing the breakage, thus reducing failure of the appliance. The 3D printed model has a more complex structure with a higher level of detail. So this is Digitainer or the digital space maintainer. You can see that it is impression is made using the intraoral scanner, and thereby it is completely done outside and potential for usage in children because of their impressive advantages of precision, comfort, and a time-saving approach. This workflow helps to lessen the fear in children. It improves the child's cooperation and enthusiasm, reduces chairside time, and shortens the procedure because an impression making is not really required. The intraoral scanner makes the impression and it can be fabricated outside, and it is easy to place too. Moving on to the lingual arch space maintainer. It is a bilateral, fixed or a semi-fixed, non-functional and passive space maintainer, where it is indicated in the maintenance of arch perimeter or prevention of mandibular changes in the arch length when there's overjet and overbite from incisor repositioning. When the retention and stabilization of the mandibular anterior teeth position is important, and sometimes when teeth are lost on both the quadrants of the same arch. So this arch wire, it should be located 1 or 2 mm below the gingival margin of the edentulous ridge in the posterior regions in order to prevent distortion under forces of mastication. The arch wire should contact the erupted permanent incisors at the level of cingulum. One of the modifications of lingual arch space maintainer is a Hod's lingual arch, which has a U-loop, which can be used even for space regaining purposes. The advantages and disadvantages, you will be familiar with it. Moving on to the next modification of lingual arch is the functional lingual arch with hinge type lockable Densulus component. The advantage of this being, this appliance helps in mastication as it is functional. The underside of the Densulus component can be cleaned upon opening the Densulus component. There is a prevention of over eruption of the antagonistic tooth, and eruption of the premolars can be checked without debanding. For the special children, a metal-free space maintainer is indicated. It can also be indicated to patients who are allergic to metals. And this is indicated specially for these special need children because they often need to undergo MRI in the head region. So the advantage of this is it's totally metal-free, aesthetic, easy to clean, light, comfortable, and it is a fully digital work. The appliance is completely based on the digital technology, and custom-made metal-free CAD/CAM device is used. Fiber reinforced composite is used for this, and this is directly bonded only on the palatal surface of the first molar without etching, and specific dual curing cement with fluoride release and without bisphenol A. Nance palatal arch is a bilateral fixed passive non-functional space maintainer indicated in bilateral missing primary molars in the upper arch. It can be combined with incorporation of spurs and acrylic button for habit breaking. This acrylic button is placed on the slope of the palate, and this will provide an excellent resistance against any forward movement. This wire will extend from the lingual of bands to the deepest and the most anterior part in the middle of the hard palate. The U-bend is given in the wire 1 to 2 millimeter away from the soft tissue for the sake of retention in the acrylic. The disadvantages, oral hygiene difficulties, and poor patient tolerance. In case where there is a avulsion of the permanent central incisors, then this modification of Nance palatal arch where the adolescent natural tooth is used, and this will be welded and soldered to that of the permanent first molar band, so that this will act as a modified Nance palatal arch appliance for an anterior tooth replacement. The transpalatal arch, or otherwise known as a Goschkerian appliance. It is a bilateral fixed, passive, and a non-functional appliance when one side of the arch is intact and several primary teeth are missing on other side. It helps to prevent the molars from rotating around the palatal roots, which is the first movement which will usually start taking place in the loss of space in the arch perimeter. And for this construction, a 0.036 inch wire is taken and it will run across the palatal vault and it will be off the tissue. The U shape will be bent in the middle third of the band. This is also considered as an alternative to Nance appliance because this also helps to maintain the arch width, derotate unilaterally or bilaterally rotated molars. It can control upper molar eruption and correct unilateral cross bites for maxillary expansion and buccal root torque of upper molars. It can correct mesiodistal asymmetries too. The distal shoe space maintainer is otherwise known as an intra-alveolar appliance or the eruption guiding appliance. It's a unilateral, fixed, non-functional, and a passive space maintainer. Willett in 1929 presented the first space maintainer with a distal extension for the premature loss of primary second molar. And since the abutment teeth needs to resist the strong eruption force of the lower first molar, he covered the primary first molar and the canine together in a casting. And this extended distally, and this looked like a shoe, thereby it is known as a distal shoe appliance. The commonly used one is the one that is described by Roche, which will have a V-shaped end. So these are various indications and contraindications for distal shoe space appliance as by the Hicks criteria. To construct the distal shoe, we have the horizontal extension, which will be bent at the right angle bend. The gingival extension of the vertical bar will be 1 to 1.5 mm as per McDonnell, 1 mm as by Profit and Pinkham, and 5 to 7 mm as by Bijou and Cooley. Construction of the loop will be contoured with 0.040 inch wire, which will extend distally into the prepared opening on the model. The position and the width of the distal extension In a way, it is slight lingual position will be given over the crest of the alveolar ridge so that it will engage the mesial contact area. To get the length of the distal extension, if the opposite second primary molar is present, that width can be measured, and based on that, it can be compared with that the radiographic measurements. So this will make it more simple. The appliance, how it is going to be placed. If the extraction site is healed, the knife edge is formed at the apex of V. So the sharpened distal shoe will be forced through the tissue in the anesthetized area of the ridge. If the appliance is delivered at the time of extraction itself, intragingival extension is just polished and it is not sharpened. So before the final placement, the radiograph will be taken to determine the tissue extension of the appliance, whether it is in proper relationship with that of the unerupted first permanent molar. Various modifications for distal shoe is one is the crown distal shoe, the other removable distal shoe, the pressure appliance, and another one is that of the where the vertical depth of the intra-alveolar projection will be calculated radiographically, and a cut will be made in the cast with wire components adapted using the 19 gauge wire. In this, if there's a multiple loss and if the other quadrant requires pulpectomy and crowns, this can be modified and a lingual holding arch will be given and posterior wire component will act like a distal shoe. The other modification that was given by Anagundi et al. Is that it has horizontal U-loop, which will be used for activation if signs of space loss is there during the follow-up period. When compared to Willett's appliance, these cases showed mesial tilting, space loss, or signs of ectopic eruption in Willett's appliance. The advantage of this appliance over Willett's is that it has increased flexibility, it has broadens the contact area and prevents dislodgement. At the buccal and lingual arms of the horizontal component, U-loops will be distributing the stresses from the first molar during the active eruption stage. There is no signs of breakage and dislodgement, and it should be able to withstand the stresses of eruption. So in case of anterior space loss, a Groper's appliance can be given, and this was further modified along with the primary first molar or the primary second molar. If it is restored, then along with that, it can be given. So it is a Groper's appliance with stainless steel crown and customized teeth, which is known as a Grassi appliance. Moving on to the next space maintainer, it is the EZ space maintainer. This was developed by Ennis Guret. It is less time consuming when compared to the traditional space maintainer appliance. It does not require any impression or a laboratory construction. It can be directly bonded. This is available as a fixed appliance, which provides easy maintenance for the mesodistal dimension. And this uses the nitrate coil. There will be 4 different colors. The green will be used for upper right. The yellow will be used for the upper left. The red will be used for the lower right, whereas the white will be used for the lower left. Once the space maintainer is taken, then this adjustment can be done by squeezing one of the tube with a heavy cutter plier, and later on it is bonded onto the tooth surface. The longevity of space maintainers in a retrospective study, it was found that band loop space maintainer showed the highest median survival time, and this should be favored as a space maintainer design whenever possible. And when a space maintainer fails because of cement loss, careful reassessment is required. A close supervision and frequent follow-up appointments are necessary to check the integrity of the luting cement and also to clean the abutment tooth as and when required. In bilateral fixed appliance, a 2-month follow-up, and in removable or unilateral, a 4-month follow-up would be advisable. Next, moving on to the bonded space maintainers. One such bonded space maintainer is a new universal space maintainer. There we have solid steel foil pad bases, which will have 0.036 round rectangular wire, and stainless steel tubing will be there. The excess wire will be cut off and it will be inserted and then crimped. The other type is the spiral wire bonded space maintainer. In this, instead of the routine round wire, the multi-stranded ortho wire, the diameter of 0.032 diameters will be more satisfying and it will be more useful, as mentioned by Artem and Marstander. This is another appliance. If there is going to be an early loss of permanent first molar, what can be done is a wire component can be made in the form of this zigzag pattern over which an acrylic tooth can be given after banding the permanent first molar and the permanent second molar and the primary second molar, thereby aiding in mastication at the same time maintaining the space until further treatment is required. Moving on to the removable space maintainers, the indications and contraindications, you will be aware of it, and the classifications too. I'm not going into detail on the removable space maintainers. Now, I would like to show you a couple of articles which will be useful for you. And one is on the rate of closure, the incidence and nature of space closure following the premature extraction of deciduous teeth. This will talk about the loss of D or E in a yearly manner, whether it is D or E which has greater space loss, and that D plus E has a greater space loss when compared to D or E alone. This will be another follow-up study for the primary maxillary first molar, mandibular, and mandibular primary second molar too. This is systematic analysis that will be useful for lower lingual arch. This is a flow chart which you can find in Contemporary Orthodontics, which is taken from the book Profit, which will help you to plan your space maintainer. An interesting article by Terlage is very important, where you'll be able to have treatment planning for space maintainer in the primary, early, and in the late dentition period, and also space maintenance planning in the primary and mixed dentition period. This slide shows at various time intervals the survival rate of the space maintainers by various authors mentioned here. So moving on to the adverse effect of space maintainers, dislodged, broken, or lost appliances, plaque accumulation, and there's an increase in microorganisms, increase in periodontal index codes, when there is caries or damage or interference with the successor eruption, undesirable tooth movement, inhibition of the alveolar growth, soft tissue impingement, and pain. This is an interesting article that I came across, which shows that there is a very low evidence to suggest in this systematic review that space maintainer and regainer are really effective in preserving the arch length and preventing mild to moderate crowding in children, especially during the mixed dentition stage at the expense of lower incisor proclination. However, considering the low evidence provided by this systematic review, high quality studies are required. So based on all this that we have covered, these are the questions from the past, and I have covered the questions that I've mentioned here too. So to conclude, emphasis must always be to use the primary teeth as a natural space maintainer. In case of a tooth loss, a proper space management strategy is necessary, and guide the teeth into normal tooth position is the best approach. And this can be done through proper diagnosis, thoughtful appliance design, and parent education so that they understand the value and responsibilities with regard to the appliance, as they are the key factors for a successful space maintenance. I thank you for listening. I hope the PGs found this program useful and you are able to take home some points from this presentation. Thank you so much. I thank again the organizers of Virtual PedoRare 3.0, the ISPPD head office, and KSR Institute of Dental Sciences and Research for giving me this opportunity. Thank you so much, and best wishes to the exam going postgraduates. Thank you.
Thank you, Dr. Vinola. We will have the question and answer session at the end of the three sessions. Okay. So we'll start with the next session by Dr. Nipu. Okay, I think moderators are busy with their some other meeting. I think they'll join shortly. So I take privilege in introducing Nupur. She's completed her BDS in 2005 and MDS in 2010 from Subharti Dental College and Hospital, Meerut. Her areas of academic interest are preventive dentistry, surgical pediatric dentistry, including electrocautery and lasers. She has been a recipient of various awards such as Best Paper Awards by ISPPD in 2014. She received Distinguished Women Award in 2020 by ISPPD and Research Excellence Award in 2020 and India Diva Award for Excellence as Pediatric Dentist in 2022. Currently, she is an EC member of ISPPD and is working as a professor in the Department of Pediatric and Preventive Dentistry, Subharti Dental College and Hospital, Meerut, for more than 12 years. We welcome you, ma'am, and she'll be presenting her paper on mouth breathing and thumb sucking habits.
Thank you so much. Welcome to virtual PedoRare. Jai Hind one and all, I bring you greetings from Subharti Dental College, Swami Vivekanand Subharti University. Myself, Dr. Nupur Kaushik, and today I would be presenting on thumb sucking and mouth breathing habits. But before that, I would like to extend my heartfelt gratitude towards KSR Institute of Dental Sciences, especially towards Sharat Ashokan sir and Dr. Geeta Priya ma'am, along with the office bearers of ISPPD head office. And not to mention about a very dynamic personality who guides me is none other than Dr. Nikhil Srivastav sir, and this is the small pedo family that I have in my institute. A small disclaimer that the entire content of the presentation is for the educational purposes, and whatever matter I have collected is either from the books, journals or internet, and some have been added from my personal clinical experiences. Any clash of opinion is purely coincidental and deeply regretted. Now these are the various examinations, these are the various questions that have come across in different universities, and habit questions, they are either asked in a long essay form or in a short note. So if you get a long essay, then how will you write that question? Firstly, please frame an outline for that particular question, and these are the certain headings under which you're going to outline your question. Now the question arises that generally these are the same things that we do in our BTS. That how does it differentiate us from being an MDS students? Please remember, you have to support each and every answer with relevant studies. Now before beginning my presentation, I would like to tell about a famous quote that I came across was that the habits we form from childhood, they make no small differences. Rather, they make all the differences. Now these are two famous personalities. You must be wondering why did I put them here. One is from Bollywood and the other is from Hollywood. So why I have put them here is because one of them, Mr. Ranbir Kapoor, he was a mouth breather, and Emma Stone, she was a thumb sucker. Now you can see that they both have got rid of their habits and they are so successful in their respective fields of life. So moving on further, if you have to define habit, what will you say? Habit is a tendency towards an act which has become a repeated performance, relatively fixed, consistent and easy to perform. And somewhat it has become almost automatic. So this is the definition that was given by Boucher, and I expect all the postgraduate students to learn this. Now for a prevalence study, a study was conducted in the year 2003 by Kharbanda et al., who did this study in school-going children of Delhi. And he concluded that prevalence of oral habit in Delhi was approximately 25.5%, in which Tongue thrusting was the habit that was commonly seen among children. Another study that was conducted in 2015, it was approximately 3,600 children under whom this study was conducted, and it was found out that 16.8 children had one or the other habit, and because they took children from two different zones of life, like one from the municipal schools and one from the private school, so the author further concluded that the municipal school children, they had more type of habits, and boys were more prone for such oral habits. And again, the tongue thrusting was found to be the most common habit, followed by thumb sucking and mouth breathing. So when you are writing about habits, any habit, please remember you have to mention the various classifications that have been proposed by different authors. So one like Shobha Tandon ma'am had given, in which she had classified habits as obsessive, non-obsessive. According to James, it could be useful, harmful. Further, Kingsley has classified habits, Morrison, Bahana, clean, and the one that is most commonly used is by Finn, which says that the habits are either compulsive or non-compulsive, which further to understand is that some habits are deep-rooted and they have some emotional need. So, they cannot be very easily acquired or discontinued. Rather, the non-compulsive habits, they mean that these are habits which can be very easily dropped or added into a child's personality. Now, moving on further, you have to remember that whenever you're talking about any habit, remember please that all these habits, they have some amount of pressure they extend on the oral musculature, because of which the dentition gets affected. If you remember in our prosto, we were taught about the neutral zone. Now what does this neutral zone? It is the teeth are aligned properly inside the oral cavity. How? Because from the inside the tongue balances, the force of the tongue balances, and from the outside the buccinator and the orbicularis oris, it balances. And that is why the dentition is properly aligned. Whenever in any of these habits there is an imbalance of the force, you will find that either your maxillary will protrude out or you'll have a high arch palate. So remember, it is basically because our neutral zone got affected. So whenever you're talking about any of these habits, remember, habits, whatever manifestations of these habits will occur in a child, it will be because of FDI. Now what does this FDI stands for? F stands for frequency, D stands for duration, and I stands for intensity. Further, Pinkham added another magnitude to this was direction. So, when you have to think about habit, what are the effects of this habit, how and for like what magnitude the effects have to be seen, it is basically categorized as, it could be because what was the intensity of the habit, what was the duration of the habit, what was the frequency of that habit, and lastly, the direction of that habit. So moving on with the first habit that we have for today is mouth breathing habit. It is the simplest of all the habits because the name itself tells you what the habit is all about. So it is a habitual respiration through the mouth instead of the nose. Now, Finn has classified mouth breathing as anatomic when you have short upper lip, obstructive whenever there are obstructions present in the nasal cavity, and habitual. You have removed the cause but still the child is persisting with this habit. A prevalent study was conducted in this regard in Brazil in a population of approximately 23,000, and what they found out was that 55% of the children were mouth breathers. Now there are many transition stages also when you will come across that the child is breathing through his mouth, but make sure you try to convince the child to discontinue this habit as early as possible. Now, if we talk about the etiology, mouth breathers generally, it's not of habitual or anatomic, there are mostly it is because of the obstructive causes that a child suffers through. Now, what could these obstructions may be? It can be because of the enlarged turbinates, because of which the passage of air is not proper, and to compensate the deficiency of the air, the child opens his or her mouth. Secondly, it could be because of the hypertrophy of the pharyngeal lymphoid tissues. Now, to recall, in our BDS or MDS first year when we were having an anatomic classes, we have learned that there is something known as Waldier's ring. What it is an interrupted circle of protective lymphoid tissue at the upper end of the respiratory and alimentary tract. So what does it helps us? It helps us in preventing infections. Now what happens? This Waldier rings, it consists of 4 types of tonsils. 1 pharyngeal, 2 tubal, 3 palatine and 4 lingual. Now among these, tubal and the palatine tonsils, they occur in pairs, and pharyngeal and the lingual tonsils, they occur as solitary. Now whenever there is hypertrophy of the pharyngeal tonsil, it causes a restriction in the passage of the air near the nasopharynx, and because of which the child is forced to breathe through her mouth. Now, another obstruction could be any intranasal defect, and most of us would be suffering from deviated nasal septum and allergic rhinitis, which occurs whenever there is change in the season. Now, what are the effects of mouth breathing? How could you come to know that particular child is a case of mouth breather? There are particular extraoral features that you could jot down which helps you in noting that the child is a mouth breather. Firstly, you will see the facial form of a child. Generally, the child who is mouth breathing will have a vertical growth pattern, and because of which you will find there are underdeveloped infraorbital tissues. Now, if it is because of the hypertrophy of the adenoid tissues, these children, they have a typical appearance, which is known as adenoid faces. And what comes underneath? You'll find a child with a long, narrow face. The child will have flaccid lips. That means there is no tonicity of the upper lip and an expressionless face. Further, if you open up the oral cavity of that child, you will find out that generally there is protrusion of the maxillary anteriors, because of which if the palatal vault is constructed, now you have to recall back your neutral zone, that means it is affected in this habit. So when your neutral zone is affected, your teeth are not properly aligned because of the increase in the pressure which goes inside the mouth, the oral cavity, the palatal vault, it becomes high arch, and you will find posterior cross spine. Generally, the hyoid bone is elevated in these patients, and you will find out that there is an increase in the mandibular plane angle. Further, a study was conducted for the comparison of cephalometric patterns in mouth breathing and nose breathing children, and it was concluded that the mouth breathers, they have increased anterior lower facial height, elevated hyoid bone and retruded mandible. Other features which are decompose these habits are the patient might be suffering from otitis media. Now here you have to recall that there is a connection between the nose and the inner ear, the eustachian tube. Esophagitis, because you're breathing through your mouth, there are no hairs present inside here, so no cleansing of the air would be there. Atrophic nasal mucosa, the patient might have a nasal tone and he might suffer from sleep apnea syndrome. Now, how does this sleep apnea syndrome occurs? It is because there is enlargement of the lingual tonsils. Now, whenever there is enlargement of the lingual tonsils, whenever the mouth breather lies on his or her back, the tongue falls posteriorly. When the tongue falls posteriorly, it touches the posterior pharyngeal wall, and then it closes, or there is no freeway passage of the air there. So it occludes the oropharynx and the patient snores out. What other symptoms you could find in such a patient is, apart from snoring, that there is altered state of consciousness and morning headache. Now, how could you diagnose a case of mouth breathing? Firstly, take a proper history from the parents. Please ask them whether the child is sitting in a resting position, or when the child is sleeping, are the lips apart. This is a very big hint by which we can come to know whether the child is a mouth breather or not. Apart from that, you ask them about oats. So we are not going about the oats that we eat, but you ask them whether the child is suffering from otitis media, allergic rhinitis or tonsillitis. Now you have to remember there is a connection of the nose with the eustachian tube again. You have to correlate this, you have to correlate one with the other or vice versa. When a child is sitting in front of you, please observe the lips again. You will see that whether the lips are in tight contact or they are far apart from one another. Another thing that you have to notice that when the child is breathing in and out, is the dimension of the nails changing or it's constant? If it's changing, that means the child is breathing through his or her nose, and if it's constant, that clearly indicates that the child is a mouth breather. Further, you can perform mirror test. You place a mirror wherever the fog occurred, that tells you where the passage of air from. Water holding test, you ask the child to hold water. If he or she holds properly, that means the child was breathing through her nose. If not, mouth breather. And the butterfly test. These butterfly actually doesn't mean we are putting butterfly here, but the cotton is shaped in a type of a butterfly. And if the upper cotton flutters downwards, it means the child is a nasal breather. And if it flutters upwards, it means that the child was breathing through her or his nose. Apart from this, you can go for cephalometrics. In cephalometrics, what you have to see the pharyngeal space. If it is because of the hypertrophy of the pharyngeal tissue, you will see that the passage of the air has been reduced. And another test which you can perform is rhinometry. Now, rhinometry measures the ratio of the oxygen and the carbon dioxide, and it tells you whether the child was a mouth breather or a nasal breather. So now the question arises, how will you manage this child? So first and foremost, what you have to do, you have to eliminate the cause. Suppose the child is a mouth breather, because of any of the obstruction, please remove those obstructions. Secondly, ask the child to perform some myofunctional exercises, which I would be discussing in the later part of the presentation. And thirdly, you have to intercept the habit if it continues even after the elimination of the cause. Now, what are these exercises that we are supposed to guide the child to perform? First and foremost, an article was published in our very own journal, and various exercises that have been published are that you have to ask the child to pull her or his upper lip. What you have to guide them, you have to guide them that please pull the upper lip towards the palatal aspect of the maxillary anteriors, and over it you put your lower lip. It is really, really difficult. You all can try it on yourselves. You have to ask the child to pull in air, fill in airs in his or her mouth. Button and string exercises, the simplest of which is that you insert a pen inside your mouth and you ask the child, please refrain it from pulling inside with the help of your lips. So that becomes or increases the tonicity. Then you have to ask them that they can simply blow balloons. This is simplest. Give 10 balloons to the child and ask them to blow in air. It helps in getting back the tonicity of the upper lips. These all exercises are very simple and they can be easily performed in the house itself. Then third is the appliance therapy. The most common appliance that we advocate to a child who is a mouth breather is the oral screen. Now the question that comes again is, what is a vestibular screen and what is an oral screen? Remember, vestibular screen covers our vestibular surface, but if an oral part is associated or is a part of that screen, then that becomes the oral screen. Now, what is the principle of this vestibular screen? It works on the principle of force, application, and elimination. And it acts as a solid shield which is inserted in the mouth. Now, how will you come to know that the oral screen is working in your patient or not? When you deliver this oral screen to a patient, it is always in a passive state. When the patient comes back to you for a follow-up and the patient tells you that, no, I am feeling somewhat tightening of the appliance, then that tells you that this oral screen is working on that particular patient. There are certain modifications which have been proposed for oral screen, like the cross modifications, in which you make holes, the HOTS modification, in which a ring is inserted onto the oral screen, and the rehack modification, in which a pacifier is added to an oral screen. Now, all these modifications, they depend what type of mouth breather you are getting. Also, apart from these oral screens, you can give myofunctional strainer to a patient. What is the principle? It retains the mode of the tongue position and action. Now, in short, if a patient of a mouth breather comes to you, what are we supposed to do? We are supposed to perform tests, and then you have to refer the patient to an ENT surgeon if the patient is diagnosed as a mouth breather. Now, what the ENT surgeon will do, he will see that whether there is an obstruction in that particular patient or not. And if he finds any obstruction in the nasal cavity, he is going to remove it. Now, after that removal, you can go for your therapy if the problem persists. On the other hand, if your ENT surgeon says no, there is no obstructions, it is only habitual, then you have to fabricate the plans and deliver it to the patient and keep the patient on the regular follow-up. Now, this is one mouth breathing patient that we had in our department. It had come in the month of February itself, so the recall of the patient is due, but you can appreciate how we had modified the spacer. This is very clearly written in Graeber and Newman that you have to modify spacer according to the situation of the patient's oral cavity. Now, a recent article has been published in our ISPPD journal only, which was the correlation and comparative evaluation of the nasal index and the nasal cavity volume. And the author concluded that there was a statistical significant difference in the nasal cavity volume and the nasal width between the mouth breather and the nasal breather. However, the nasal height and the nasal index did not show any significant difference. He further said that we need to perform more and more studies on a larger sample size. Now, moving on to the second habit that we have is digit sucking or thumb sucking habit. So these sucking habits, they are classified as nutritive sucking habits or non-nutritive sucking habits. Nutritive sucking habits include breastfeeding and bottle feeding, and non-nutritive sucking habits, they include digit sucking and pacifier sucking. This habit is generally seen, or we can say it otherwise, that it is very commonly seen or early diagnosed in a child of 29 weeks of intrauterine life. And this habit gradually disappears in 1.5 to 2 years of age. However, if it further persists, then that becomes a habit in an individual. So by definition, what do you understand? It is the placement of thumb or your digit at various depths into the mouth. Now, there are two classifications that have been proposed for thumb sucking. One, which depends on the depth of the thumb placement, and second, that is based on the severity of the habit. Now, the most common that we read about is the one which is based on the depth of the placement of thumb. This classification was proposed by September. He classified into 4 categories, type A, B, C, and D. And then he further said that type A is one which is most common, and it is approximately seen in 50% of the children who place their thumb, complete digit, into the mouth and press against the palate. This is the second classification which I was talking about, and it is based on the severity of the habit. Now, there are various theories that have been advocated, like the psychoanalytical theory, which was proposed by Sigmund Freud. According to him, habits evolve from an inherent psychosexual drive, where the child derives pleasure during thumb sucking. Also, another theory that was given by Sears and Weiss, which says that prolongation of the nursing strengthens the oral drive. The Benjamin theory advocates that the movement of the infant head and tongue is generally seen towards an object that touches their cheek. And the learning theory tells that the infant associates sucking with such pleasurable feeling. When he recalls that whenever I was hungry, I used to suck something. So now he recalls that these events by sucking the suitable object available, which is thumb or finger. Other positive factors would be socioeconomic status, working mother, number of siblings, and if there is any stress associated with the child. Now remember that the time of appearance of the digit sucking habit has a significant role. Why? Because if a neonate is sucking thumb, it is pretty normal. It is also acceptable during the first weeks of the life. You have to be cautious when the child is sucking thumb during the eruption of the primary molars, and you need to intervene if the habit continues after the age of 4, 4.5, and dental changes are seen in the patient. So how will you diagnose whether the patient is a thumb sucker or not? Please ask about the feeding pattern from the parents, the parental care, whether the parents are available for the child, is the child having any insecurities, and is there any other habit which is associated with thumb sucking. Now, when you see or look at the digit, whether the child is sucking thumb or digit, you will see callus formation around that finger or digit. And you will see that the nails are clean and dish-shaped. When you look towards the lips, you will see that the lips are cracked, and generally these patients, they have dry lips. Why? Because the mouth is more or less open in these patients. Now, what do you understand by facial form analysis? When you analyze such a patient, you will see that these patients, they have mandibular retrusion and maxillary protrusion. The facial profile is generally convex or flat, and you will find that the lower lip is everted up because of the excessive mentalis muscle contraction. Moreover, associated symptoms could be habitual, that the patient is a habitual mouth breather, and you can see that if a patient is a mouth breather also, you can very well appreciate that the marginal gingiva is highly inflamed, and it is plaque deposition is very, very common in such patients. Apart from that, the patients might develop the tongue thrusting habit, any middle ear infections because of the association between these two, and enlarged tonsils. When you look at the intraoral features, you're going to see that the child might have an open bite, deep bite, mandibular retrusion, incisors, or they might be aligned only. Now, everything what I am speaking depends on the severity, the pattern, and the amount of digit which is placed inside the oral cavity. So, you'll find different features in a child who's a thumb sucker. Apart from that, the child will have a V-shaped high palatal wall, and because of which the posteriors are generally in a crossbite. To understand better, there is a Buccinator mechanism which says that when the child places the thumb between the teeth, a negative pressure is created. And what does it do? It lowers down the tongue. Now, when the tongue gets lowers down, there is a pressure against the upper anterior because there is no counterbalance for it. So what happens? The cheek pressures against the upper posteriors, because of which the child develops the posterior crossbite and proclination of the anterior teeth, and the palatal vault is high arch because of this. So now the effect on maxilla, what you would see, just to recall, there would be proclination, diastema could be there, increased maxillary arch length, increased SNA angle, and the palatal width would be decreased. The lips, they are incompetent, and tongue, the child can develop a tongue thrusting habit. Mandible, you might find retroclination of the mandibular incisors, and it again, I'm emphasizing that it depends on the placement of the thumb, whether the thumb are resting on the mandibular incisors or they are just hanging in the air. And when you talk about the interarch relationship, you'll see that the posteriors are generally in crossbite. In this context, a study was conducted which concluded that the lower position of the tongue in the non-nutritive sucking leads to dentoalveolar expansion of the lower arch, and the opening of the upper and the lower jaws increases, because of which the vertical dimension increases. This effectively heightens muscle contractions in the cheek near the canine teeth, leading to an inward or narrowing face directed against the maxillary arch form. So how will you manage if a child is a thumb or a digit sucker? First, as we all know, prevention is better than cure. So we have to see that the child gets engaged into different activities, and instead of placing the thumb in the oral cavity, we can use dummy to get rid of this habit. Apart from that, you have some psychological methods. Now you can remember that this beta hypothesis or Dunlap hypothesis also comes as a short note, according to which the child is forced to concentrate on habit while he practices it. And generally, when the child observes that he and she is involved in a bad habit, they try to discontinue. Now remember, Dunlap hypothesis can be applicable only to a child who understands your language. A 3-year-old child, and you try to explain this habit by saying, no, you shouldn't put it because you look bad. It's really difficult for a child to comprehend to that level. So how can you help a 3-year-old child or 3.5-year-old child? You can tell them that Mr. Thumb, he's a bad boy, he's a bad guy, and we shouldn't let him put himself or herself into your mouth. So this way, cooking up stories, you can ask the child to refrain from this habit. Apart from this, you can also go for some reminder therapies, which could be either chemicals, any bad tasting chemicals you can apply to the thumb, or you can go for mechanical therapies. These mechanical therapies, they include either you apply a thumb guard, you give long sleeve gowns to the child, you put ace bandages on the elbow so that the child is not able to bend his or her hand. Then you can cook up the stories like the thumb home concept, that the thumb stays in his home, you shouldn't disturb him. Or the recent advances is that we have, which is the 3 alarm system or electronic habit reminder. And in both of these systems, an alarm goes off whenever the child tries to put his or her thumb into the oral cavity. It has also been seen in a study that these non-nutritive sucking habits, if they are ceased by the age of 6 years, whatever changes are there, it's transient. And it gets back to their normal position. However, if these habits they persist beyond the 6 years of age, there is less likely to result in spontaneous resolution. What all appliance therapy you can give to a child who's a thumb sucker? First and foremost, we can give an oral screen also, and we can give a blue glass appliance. What this is blue glass appliance? It consists of a Teflon roll. So what you have to ask the child to do that instead of placing the thumb onto the palate, please place it here and try to play with these rollers. Various modifications of these Teflon rollers are there. Like instead of one, you can give 2 beads. And in many cases, you can also give palatal crips or hearings. So this is a case of thumb sucking that is being done in our department. She's a 13 years old child. So if you try to go for a preventive or a psychological therapy, it won't work. Neither the chemical therapy would work here. So we had given this palatal crip to this girl, and she is due for her follow-up appointment. So if I would like to conclude, I would simply like to say that habit is a socially unacceptable act. And the identification of any abnormal habit and assessment of that particular habit for its immediate and long-term effect on the craniofacial complex is important, and it should be done as early as possible. These are the some suggested reading that I have for the postgraduates. If you could find time, please go through these articles. It would be a real help for you. These are the list of my references by which I have made my presentation. Any amount of appreciation, criticism is highly accepted. If you have any questions, please put it in the chat box. I would like to answer those, and if I'm not able to, I'll simply try to find an answer for those. Thank you one and all for your patience learning. Once again, I would like to pay my heartfelt gratitude towards the ISPPD head office and KSR Institute of Dental Sciences for giving me this opportunity. Thank you all. Have a good day.
Thank you, Dr. Nupur, for that extensive lecture. And now I request Dr. Parimala to introduce the next speaker of today, Dr. Anshula.
It was a nice presentation, Nupur. Congratulations. Now I'm really happy to introduce my friend, Dr. Anshula Deshpande. She is MDS, MBA, and PhD. Presently working as a professor in the Department of Pediatric Dentistry in KM Shah Dental College, Vadodara. And she is a professor and PG guide. Her area of interest are early childhood caries, preventive and interceptive orthodontics, pediatric endodontics, MIH, and dental education. She's been guest lectures in more than 45 forums at both national and international levels. She has more than 120 publications with more than 42 research projects completed, and 8 are ongoing research. She has many awards like Vidya Tandon Memorial Gold Medal Award for the postgraduate student in 2004 from Manipal University, International Association of Dental Research Colgate Research in Prevention Award in 2006, and Best Paper Award in 40th and 36th ISPPD Conference, Best Poster in International Conference, Award Research Award in 2018, and so on. This continues. So I welcome Dr. Anshula Deshpande to give a lecture on interceptive orthodontics. So, welcome, Dr. Anshula.
Thank you so much, ma'am. Thank you so much, ma'am.
Not that everything will be available at the college. So electors, we would like them to have the to take it from office. So if they can take that course, then it
Thank you so much, Dr. Radhika Mupa ma'am and Dr. Parimala ma'am for moderating the session. And at the outset, I would also like to thank our President and General Secretary, Dr. Mosmi ma'am and Nikhil Shrivastava sir, and Team PEDO, KSR Institute of Dental Sciences and Research Center for organizing virtual PEDO Rapid Review Course 3rd edition. And as you all know, I'm here with you all for talking on the topic twin block therapy in mixed dentition, which is a very upcoming area in pediatric clinical dentistry. Now let us move on to the various questions which have usually appeared in the theory papers. So I came across that mostly there were short notes on twin block appliances, modifications of twin block, or management of developing class 2 malocclusion, or in a way, importance of myofunctional appliance. There was a long question which was on present concepts of early orthodontic intervention in children, which will involve many aspects, including myofunctional appliances. Now, if you get a short note on myofunctional appliances, this should be your content: introduction, definition, history, classification, diagnosis, what were the treatment principles, advantages and disadvantages of myofunctional appliances. And if it appears as a long question, then you can add few important myofunctional appliances with its indications and contraindications. Now let us move on to the direct question on twin block. So if that is the question, then you should start with small introduction, development of twin block, indications, mechanism of action, then diagnosis and treatment planning, followed with byte registration and fabrication of appliance. Design and construction of twin block can be elaborated or can be used with the help of diagrams. Then what is standard twin block? The stages of treatment, and then what are the various modifications in twin block, followed with few important landmark studies, RCTs, and systematic review. And then you should conclude and give bibliography to your. Now, when I say introduction, let us go to myofunctional appliances. A functional appliance is an appliance that produces all or part of its effect by altering the position of the maxilla or mandible. They are also known as dentofacial orthopedic appliances, and these appliances utilize the muscle action of the patient to produce orthodontic or orthopedic forces. Now, these loose-fitting or passive appliances, they usually harness natural forces of the orofacial musculature that are transmitted to the teeth and the alveolar bone through the medium of the appliance. Now, when we say definition, there are a few important definitions, and these are the three definitions you must quote. The first given by Moyes, where he stated that functional appliances are loose, removable appliances designed to alter the neuromuscular environment of the orofacial region to improve occlusal development and or craniofacial skeletal growth. Whereas Prophet stated that these are appliances which alters the posture of the mandible, holding it open or open and forward or in backward position. Whereas Glossary of Orthodontic Terms states that functional appliance is a term used to describe a class of appliances which utilize the muscle action of the patient to produce orthodontic or orthopedic forces.
Now let us just move on and see how the history evolved over various myofunctional appliances. It goes way back to 1879 when Norman Kingsley, he came up with forward positioning of mandible by various bite planes or bite jumping like appliance, which was made of vulcanite. In 1883, Wilhelm Rox, he talked about Gould's law, and the orthopedic principle was elaborated by him. In 1909, Viggo Anderson, he modified this bite jumping appliance, which was inspired from Benno Lecher's theory. Whereas Carl Hall, in 1936, he saw the potential of Rox's hypothesis and explained how functional appliances work through the activity of the orofacial muscles. Now, the association of Anderson and Hoppel brought up Activator, the appliance which worked on biomechanical orthodontics, which resulted in functional jaw orthopedics, which also was known as Norwegian system during that time. They also collaborated in 1936 and wrote a textbook which was known as Function Orthodontics. Alfred Rogers, though 1906 is termed as father of myofunctional therapy, he was the first to implicate the facial muscles for the growth, development, and form of the stomatognathing system, and hence the credit of being father of myofunctional therapy goes to him. Whereas in 1905 and during the period from 5 to 09, Professor Emil Herbst, he worked on these myofunctional appliances, and that's why he's also known as founder of Herbst Appliance. Whereas Wilhelm Walters in 1950, he modified Activator to reduce the bulk in the palatal area, which was substituted with coffin spring, which is known as Bionator. And you all know about Martin Shaw's 1956, he talked about double plates. He combined the advantage of both Activator and the active plate by constructing the various acrylic plates separately on mandible and maxilla that occluded with the mandible in a protrusive position. Then Rolf Frankel, the Frankel regulator, which you all are aware of, came up in 1957, whereas this twin block, the twin block appliance was mentioned and given by Dr. William J. Clarks in 1977. The magnets were included in the appliances by Belchman in 1989, and that's how the revolution of the orthodontic appliances with the use of magnet came into existence. Now let us move on to classification. I'm not going in too much of depth, but this is what you should know and you should mention. At least 2 or 3 classifications should be mentioned for myofunctional appliance. The first is Graeber's classification, where it is based on the force or from where the force is being transmitted. So the group 1 is which talks about transmit the muscle force directly to the teeth. The examples are oral shield or screens. Group 2 talks about where the appliances reposition mandible downward and forward and activating attached and associated musculature. So the examples are original activator and modifications, and even our twin block appliances. Group 3 is the one where mandibular position changes by operating through vestibule, and that's why Frankel's functional regulators and oral screen are example of group 3. Profit also gave classification in 2 broad headings. The first one based on the appliance is based on tissue or tooth bone, what is the anchorage being taken, and the second was on the muscle activity. In first subcategory, it is divided into 3: passive tooth bone appliance, active tooth bone appliance, or tissue bone appliance. Now, if we are talking about standard twin block, it belongs to passive tooth bone appliance, whereas if we incorporate various expansion screws or springs, it becomes an active tooth bone appliance. Now, as based on muscle mass and activity, if they brought two subheadings is myotonic and myodynamic. Myotonic appliances, they rely on muscle mass and resting pressure, whereas myodynamic appliances use muscle activity, and the examples are oral spleen and leg tongue. Now, when I say that diagnosis and case selection is very, very important, it also refers to our specialty, which is age-defined specialty. And whatever we do, the age of the patient becomes of great importance. And why, especially in functional appliance? Because we want to utilize growth spurts, and hence evaluation of growth spurts should be done appropriately, which you all are aware of, that we have a mixed dentition spurt as well as a prepubertal spurt, in also known as adolescent growth spurts. The other diagnostic aids which is must is cephalometric analysis and the functional analysis, apart from model and photographic analysis. Now, all these functional appliances, they work on two broad principles. That is on force application and force elimination. When we talk about myofunctional or orthopedic, it's all about balance of forces or balancing all the various vectors of forces which are acting on the tooth or on the skeletal. So both dental and skeletal aspects have to be kept in mind. Now, when I talk about force application, it is a compressive stress and strain which act on structures involved and result in a primary alteration in form with secondary adaptation in function. Whereas what is force elimination? This principle involves elimination of abnormal and restrictive environmental influences on dentition, thereby allowing optimal development. Thus, function is rehabilitated with a secondary change in the form of the structures. Now, as all the appliances have its advantage and disadvantage, same is with the functional appliance. Now, let us see various advantages. It enables elimination of abnormal functions. Treatment can be started at an early age, that is mixed dentition, to avoid various psychological disturbances which have been quoted in various researches. Appliances are fabricated in the lab, thus less chairside time is spent with young patients. The frequency of patient visit is less. It does not interfere with oral hygiene, as most of them are removable, and most functional appliances are worn during night. So again, it is an advantage for school-going children. Whereas there are certain disadvantages, like it cannot be used in adult patients where growth has ceased. It cannot be used to bring about individual tooth movement. Patient cooperation becomes essential as it is a removable appliance, and it may require pre-functional orthodontic tooth movement. For example, if there is also a cross bite of any anterior tooth, has to be corrected before we move on to myofunctional therapy. Fixed therapy may also be required at the termination of treatment for final detailing of the occlusion. So some people, they consider it as a disadvantage. Now let us move on to twin block. These are, by now, you all must have made it clear that it is an orthopedic appliance. The functional appliance can be both removable or fixed, and the mode of action differs depending on the design, as I have shared with you various classifications. Now, in a nutshell, twin blocks are functional orthopedic appliances, and the effect of twin block is mostly dentoalveolar with small skeletal effect. The use of these appliances is greatly dependent on the patient's compliance, and they simplify the fixed appliance phase. So they have a tremendous benefit, and especially modifying the skeletal and the such type of skeletal and dental malocclusions or disbalance, which will be helpful in a better fixed therapy even if it is required. Twin block appliances are simple bite blocks which achieve rapid functional correction of malocclusion by the transmission of favorable occlusal forces to occlusal inclined planes that cover the posterior teeth. Whereas when we talk about monoblock appliances, they have disadvantage of patient discomfort, which is not there in twin blocks. It and such restrictions are not there. That's why it enables the appliance to be worn full time. The various indications are treatment of class 2 malocclusion, deep overbite, can be used for anterior open bite, for modifications of twin block is used in class 3 malocclusion, and also for orthopedic traction. Now let us see how it works. What is the mechanism of action of twin block? There are posterior inclined planes which has an effect on muscles of mastication, and this results in force transmission, which in turn brings bone remodeling. So in a nutshell, this is the mechanism of action, how twin block works. Now, the next segment is diagnosis and treatment planning. This is the most crucial aspect of any myofunctional or functional therapy or orthopedic appliance. An appropriate diagnosis will only result in treatment plan which will have an outcome. So as you all know, orthodontic records which require study models, radiographs and photographs, appropriate and proper clinical inspection should be done because fundamental guidelines for a proper case selection has to be understood very well. Then video of patient should also be recorded. Pre-operative OPG, because we are doing it early mixed dentition stage, so we require OPG as well along with lateral set, and the pre-operative inter-incisal height, that is overjet, overbite, all these things should also be recorded along with molar relationship. So all the things which one studies in study models. Now the visual treatment objective should be checked by asking the patient to as much as possible protrude the mandible so as to see the visual treatment objectives are achievable or not, or is it making any changes in the facial profile. The next important stage is byte registration. There are various authors who have given different aspects to it, and stated by Woodside, he stated that mandible should be positioned protruded approximately 3 mm distal to the most protrusive position that the patient can achieve. And I can bet all of you that as much as protrusive you do, it will not be more than 3 mm to the incisal edge. So yes, that is the standard. So while vertically the byte is registered within the limit of the freeway space, the protrusive movement can be approximately 3 mm distal to the most protrusive position. Whereas Roccabado, he stated that normal physiologic TMJ movement quantifies as much as 70% of the total joint space, and therefore overjet up to 10 mm in a single activation, which comes to edge-to-edge incisor relation with 2 mm inter-incisor clearance is acceptable. There are various ways of recording this. So overjet greater than 10 mm. So the initial activation of 7 to 8 mm followed by further activation is rated. So I will be talking about reactivation of twin block in next slide. But the 10 mm is the greatest overjet which can be treated in a single without reactivation of the appliance. Coming to vertical dimension, blocks should be thick enough to open the bite slightly beyond the freeway space of the patient. The various appliances for byte registration are available like George Byte Gauge or Ectopic byte registration device, which you can purchase from the market and use. Now let us move on to design and construction. Twin block appliance is both tissue and tooth-borne appliance. The anchorage is increased by extending clasp around the labial and buccal segments, and various additional clasps may be placed on lower incisor like ball-ended clasp to control the lower labial segment. So here you can see various components: occlusal byte block, Adams, interdental clasp on lower incisor, labial bow. Midline screw and springs are added into various modifications of twin block appliance, and there can be provision for extra oral traction. So all these three are the various modifications which I will share in previous slides. Now coming to standard twin block, it is usually used in class 2 div and malocclusion with good arch forms and large overjet to allow slow forward translation of mandible. So here you can see the various colorful appliances given to patients in the department. And here you can see the bite and the occlusal front view and the buccal segment view. Coming to lower bite block, it usually covers the occlusal surface of the lower premolars or destrous molars to occlude with the inclined plane on the upper block. So these are the inclined planes which you can see. It extends to the distal marginal ridge of second premolar. The flat occlusal bite block are usually made thinner buccolingually in the lower canine region, which allows freedom of tongue movement. Whereas in upper bite block, it extends from the mesial surface of upper second premolar posteriorly to the first molar. Only the lingual cusp of the upper posterior teeth need to be covered rather than the full occlusal surface usually, as it allows flexibility of clasp or ease of adjustment. So here you can see they are not covering the buccal aspect of the tooth and accordingly can be modified. Now the most important aspect or to have an achievable or the desirable outcome of twin block technique is to follow these three phases appropriately. The first phase is active phase, where twin blocks use posterior inclined planes to adjust the vertical dimension and correct the malocclusion by functional mandibular protrusion. Whereas second is the support phase, where an anterior inclined plane is used to retain the corrected incisor relationship until the buccal segment occlusion is fully established. How it is done, I will share in the next slide. And then third is the retention phase. In active phase, it is the first visit where how to insert and remove the appliance is taught to the patient. The operation of screw, the activation, how many times it should be turned is taught, and the patient is instructed how to take care and preferably to eat with the appliance on. Whereas the second visit, which is usually after 10 days, again, the activation of screw under the supervision is carried out in the beginning, and the trimming of upper block occlusodistally by 1 mm in case of deep overbite, whereas no trimming should be done in case of reduced overbite or open bite. So here you can see it's a very good article by Bessetti in American Journal of Orthodontics and Dentofacial Orthopedics, where very nicely in the diagrammatic representation they've given how to reduce occlusal surface part so that occlusal adjustment or the eruption of the molars can be initiated. Now, I told you about reactivation of twin block. It is usually done when the overjet is more than 10 mm. So to increase the forward posture, and also this is done in adult patients by addition of cold cure acrylic to extend the anterior incline of the upper twin block. Whereas lower block, no acrylic is added. So as I said, protrusive path of mandible is restricted, requiring gradual and progressive activation in various situations like overjet greater than 10 mm, in vertical growth pattern when patient cannot tolerate 10 mm protrusion in one go, in adult treatment when the muscles and ligaments are less responsive to a sudden large displacement of mandible, and in TMJ dysfunction cases. Now, as I told, support phase is very important. Here in this case, the lower appliance is left out at this stage and the posterior bite blocks are removed to allow the posterior teeth to erupt into occlusion. The upper and lower buccal teeth are usually in occlusion within 3 to 6 months. So you can see here how in a cross section this appliance looks like. Full-time wear is necessary to allow time for internal bony remodeling. And that's why this phase is regarded as an important phase, because stability is excellent after twin block treatment, which can be attributed partly to this supportive phase. The third and the last phase is retention phase. During the retention period, the appliance wear can be gradually reduced to nighttime wear, and it usually extends for 6 to 9 months. So let me share a case of twin sisters where you can see the facial profile and the chin puckering and the face, how elongated the face looks like. The cephalometric analysis with other parameters was carried out. As you can see, all that showed prognatic anteriors, and class 2 div 1 was shown by mandibular plane angle. So it was decided to give twin block appliance, and you can see the outcome was really remarkable in 9 months follow-up itself. So here you can see the overjet decreased from almost 70 to 18 to 9 mm, and overbite also decreased from 7 mm to 4 mm, which can be also appreciated by lateral profile view of the patient. Now, why removable twin block? It does not interfere with oral hygiene, doesn't interfere with shedding and eruption of teeth, and it is adjustable based on the sequence of eruption. Less chairside time is spent, patient compliance is more, and no breakage of appliance even when used for longer period. Now let me share with you a very important evidence for early treatment with twin block, which is by Brand and Wright in the year 2003. He did a multi-center randomized controlled trial on twin block appliance, and this article was published in 2 parts where he talked about dental and skeletal effects as well as psychological effect. Now, in dental and skeletal effects, they found that it resulted in reduction of overjet, correction of molar relationship, and reduction in severity of malocclusion, which I have seen in various twin block therapy, which we have carried out in the department, and I have achieved very promising results. When we talk about psychosocial effects, yes, it was also really very satisfying. It resulted in an increase in self-concept and a reduction of negative social experiences, as stated by O'Brien and Wright in their article. The subjects also reported that treatment benefits could be related to improved self-esteem of these young children. Now, the last segment of my presentation is various modifications. As you all know, that a short note on modifications of twin block appliance had also come. So quickly, I will share you the diagrams or the types of modifications done on standard twin block. So twin block for transverse development, here the screws are incorporated both in maxilla and mandible. So when it is added in both maxilla and lower plate as well, the appliance is also termed as Bowbier appliance. The second modification is for sagittal development. So here you can see more number of screws are incorporated. So in maxilla, almost 3 screws, depending upon the type of expansion you need. If more on anterior segment, then the screw is on anterior segment. Whereas if you want in posterior, so these are the 2 various shapes to bring out sagittal development with the help of twin block. The another modification is for transverse and sagittal appliance, where the patient requires both sagittal and transverse development of the arches. Here, a 3-way screw can be used in the anterior part of the palate, but the disadvantage with such screw is that it may impede the speech because of its bulk in the crucial area and may not be accepted by the patient. The another modification is twin block rosette appliance. It is suitable in adult treatment with minimum palatal and lingual coverage, whereas there is a disadvantage of this type of appliance because it requires careful adjustment to maintain symmetry, and that's why can be used preferably in adult patients. Then magnetic twin block appliance, where the magnets are used to modify the growth. So these are added to increase the occlusal context on the bite block so as to maximize the functional forces in order to correct the malocclusion. The magnets of higher strength are used in an area where more force or more asymmetry is there as compared to, so in patients who have facial asymmetry, the magnets with higher forces on one side and lower forces on the, or lesser forces on the other sides are used. Then twin block with spinner, where it can be used with children who have tongue thrust habit. So it acts as a reminder therapy and can be added to control tongue thrust or improve on that. Then another modification is fixed twin block. It is essentially used in cases where patient is not motivated enough to wear twin block for 24 hours. So fixed twin block has various components like transpalatal arch with occlusal inclined place cemented on both the sides, and there is a slot where this inclined planes are wire tags are attached and it is inserted in the brackets. Then, as you all know, for class 3 malocclusion, reverse twin block is the modification where the inclines are in reverse direction and there is a retrusive movement of mandible. Twin block of hybrid type, where Frankel's appliance of, that is the labial lip pads, upper lip pads are also attached, so that we allow twin block to bring the changes or the adding up on the increase of forward movement of the incisors, so that inappropriate alignment of maxillary incisors can take place. Now, let me share few important studies. That is randomized controlled trial. One study was done by Basel, where they compared Hurst's appliance with twin block, and they said greater advancement of mandibular soft tissue was observed in twin block group. Burhan in 2015 compared bite jumping appliance with twin block appliance, and they stated that TBA is recommended to inhibit vertical development, whereas if clockwise rotation is desired, then bite jumping appliance can be used. Parikh et al. In 2019 did a RCT whether full-time wearing is more effective or part-time wearing, and it was stated that no difference in either dental or skeletal changes was achieved by either of two over a period of 12 months of wearing the appliance. But my experience has been that more the number of hours the appliance is worn, earlier the outcome or the result is achieved. Whereas in the recent RCT by Campbell, here they compared Frankel 2 appliance with modified twin block appliance, and they stated that the acceptance parent perspective was similar for both the appliances. There are a few very interesting systematic review which I think you people would like to go through, by Santamari in 2017, Ehsani in 2015, and Batista in 2018, where they have talked about the effects of early ortho treatment, the dental, skeletal, and soft tissue effects during twin block therapy, and the functional appliances which can be helpful for in retrognaths. So let me conclude now this session. In the pursuit of ideals in orthodontics, facial balance and harmony are of equal importance to dental and occlusal perfection. We cannot afford to ignore the importance of these orthopedic appliances and techniques so that we can achieve the goals by growth guidance in the formative years of facial and dental development. So that's why we have to utilize these growth spurts and growth modification can be carried out. As a new century approaches, the integration of orthodontic and orthopedic techniques offers a new initiative in restoring facial balance for patients who present skeletal growth discrepancies. So, twin block appliance has been used as class 2 corrector of choice for decades and one of the most efficient compliance-dependent class 2 correctors based on its ability to induce mandibular elongation and also improves the profile of the patient. So, let me just state the clinical significance of this. If treated timely, growth modification and orthopedic effects with this appliance can be achieved successfully. Follow all the stages of treatment appropriately. So this is the bibliography. Also, you must be taking down the footnotes given on each slide. And thank you so much for attending this session and all the best. If any questions, you all can text me or contact me later. Thank you so much. And also I would like to thank my postgraduate students who are now faculty, Dr. Yash Shah and Dr. Aishwarya. Thank you so much.
Thank you, Dr. Anshula, for that wonderful session.
Thank you. Thank you so much for giving the opportunity, sir.
Parimala ma'am, do you want me to read the question? We'll take a couple of quick questions for. Parimala ma'am.
Hello. Yeah. Questions. Yeah, there are few questions.
Yes, ma'am. Do you want me to read the questions, ma'am? Do you want me to?
Please,
I've compiled
please.
it.
Yeah, please.
I'll just take 1 or 2 questions for each of them. This is true, Dr. Vinola, for you. There's the one. I think a couple of questions have been asked on the seam of the band when we make a band and loop space maintenance or space maintenance. There are questions whether we need to bend it towards the mesial side, towards the distal side. Is there any specific suggestions we have?
See, usually we would say that, it is better to bend to the mesial side because it does not interfere with the tongue movements. But in Profit alone, it is given that, it can bend to the distal side. But I personally feel that being bent to the mesial side will not interfere with the tongue.
Okay. Yeah. I think one of them had asked about any references to that. I think we added that it is in Profit. Preparation as such, I think it or distal. 1 second. So during the preparation, I think it either during the band adaptation, I think mesial or distal make a difference. But after you solder it, I don't think it's going to make any big difference to that. But when you actually do that, I think we always try to put it on the mesial side. It doesn't interfere with the tongue and cause any lacerations. Thank you. Well, I think there was, I think 3 or 4 questions were related to that. And one question was asked on about, I think 2 questions were asked on your take on mixed dentition analysis. Any specific mixed dentition analysis?
Always a combined method is always better. Such as a Hakaba analysis is always better. A combined method is always better.
Okay. Usually, I think the postgraduates would want to know, like whether it's primary dentition, what should they do? If the permanent incisors have erupted, what would they want to do? So, is there anything specific you ask your PG students to do?
No, if it's in the primary dentition, we ask them to follow the Boston analysis. And then, see, there was one article which was done by Dr. Shivakumar sir, where he had compared Boston analysis along with the Tanaka Johnson analysis. So where when the permanent incisors have erupted, but if the permanent incisors have not erupted and the child's first permanent molar has come, so we are still in a confusion whether the child is exactly falling into the mixed dentition stage because the child is still in the transition phase from the primary to the mixed dentition stage itself. So we just calculate the width approximately, and then we can go ahead with the analysis. The radiographic analysis, use the radiograph only as an evidence for it.
Okay. Yeah. Thank you, Dr. Manola. I think there was one more question. I think all the postgraduates have asked all the questions which is asked in the department because they asked one more question on what do you mean by a chair side space maintenance? I think it's easy take on us, like whatever we do.
yeah, whatever we do in the chair side, sometimes the chair side, the one that you're not fabricating in the lab, such as even your fiber reinforced composite that you're doing chair side, or a bonded one, any of the EZ space maintenance that you're doing exactly only in the chair side, which does not involve a laboratory procedure, we can put them under the classification of a chair side space maintainer or a preform space maintainer, which is present.
Yeah, right. Currently, we are using that preformed banded loop space maintenance, which are available in the market. So I think all that will be under the chair side space maintenance. One question: eruption guidance appliance, is it synonymous to space maintenance?
No, eruption guidance and appliance is specifically for distal shoe.
Yeah,
the specific name for distal shoe itself, intra-alveolar guiding appliance or an eruption guiding appliance. It's specific for distal shoe.
Okay. I think you did your interview part well. I think because it's all Viva-Versi questions which has been passed on to the speakers. I'll charge my questions at Nupur. Age-wise management for tongue thrusting. Nupur, can you hear me? Dr. Nupur? Anybody can take that question till Nupur joins. Anjala ma'am, anybody who wants to? Nupur here? I think Nupur is.
Could you repeat that, Sharad?
Yeah. Nupur, anything on age-wise treatment plan for tongue thrusting? Age-wise management for tongue thrusting.
Yes, sir. There are. Okay, extremely sorry for that. Sir, yes, actually, I had already mentioned that whatever habits are there, we have to decide upon the intensity, the frequency. Like suppose all these habits, whatever intervention we have to do, age, we have to only see that whatever age is of that child, will he comprehend to the treatment that we are giving to the child? Suppose a 3 years old child is coming to you and you plan to give a tongue, you plan to give a palatal clip to that child. Then you have to give it, if the dental changes are there, then you have to give a fixed palatal clip to that child. Following, if a child comes to you who can understand, then you have to give a removable also. So it entirely depends, like whatever the intensity of that is, then you have to give that accordingly.
Thank you for that answer, Nupur. Again, there's another question on that. For a 5-year-old diagnosed with complex tongue thrusting habit, right? Tongue thrust with open bite thrust, how should the course of management be? Can you hear me?
Hello.
Yeah. Can you hear me, Nupur? Actually, you can read it on the chat box or the question answer session itself.
Hello.
Nupur, I think, can you hear me?
Yes, sir. Now I can hear.
Okay. Now there's a question. I think it's all the clinical scenario cases which the students are asking. A 5-year-old diagnosed with complex tongue thrusting, right? With open bite as well.
Actually,
so what
sir,
could be the cause of
tongue thrusting is the most complex one to treat on. I think other habits are very simpler. So if you have a complex tongue thrusting, that means the patient would be having a lateral also, tongue thrust, and the patient would be having the incisor tongue thrust also. And what you have to do, we have to give or fabricate such an appliance that prevents the protrusion also and that prevents the posterior crossbite also. So definitely, like in that cases, we can give an oral screen also in which we had given a palatal clip also, because the oral screen will take case of the whatever crossbites are there, and the palatal clip would take case of the habit. So we have to manage it accordingly.
Okay. One last question to you. Can you again explain the difference between a vestibular screen and oral screen?
So suppose a patient or mouth breather comes, only a mouth breather. So whatever screen we are fabricating or delivering to that patient is a vestibular screen, because that is covering only the vestibule. Suppose a patient of mouth breather comes to us along with a tongue thrusting habit. Then we give a oral component also to that patient because we want to get rid of both of these two habits, and that becomes an oral screen. So this is if we add another component to a vestibular screen, then it becomes an oral screen.
Thank you, Nupur. We'll have some questions for Dr. Anshula. Is twin block appliance beneficial in mouth breathing patients and patients of OSA?
Mouth breathing patients.
The question was asked in this thing.
Done because it will not break the mouth breathing habit, but yes, it will help in expanding the oral cavity. So the airway passage will increase with expansion. So there are various studies done on maxillary expansion, which states that it improves the breathing. So if we are adding expansion screws and it's an active twin block, then maybe it will, but it is not a habit breaking appliance. So because twin block is a 2-component appliance, it will not work as vestibular screen works to break the habit. Whereas, yes, it will help in expansion. So yes, that in that way, twin block may help. But it is not a habit breaking appliance.
Okay.
It will improve the airway passage and improvement in the nasal breathing will happen with it.
There's another question on twin block. After a lot of cases have been with twin block therapy, there's results in some open bite. Is it always mandatory to do a fixed appliance after twin block therapy? What's your take on that? So some patients get open bite after twin block. That's the question asked by Sudhir Kumar.
If they're getting open bite after twin block, that means the support phase was not carried out appropriately, because we have to allow, or it was not done, the regular monitoring of the occlusion was not done from change from active phase to support phase. So these things have to be monitored. And the second question, which says the fixed therapy, yes, in few cases fixed therapy may be required, but if we follow all these two stages, that is active phase, active stage, support, and then the retention phase, most of the cases fixed orthodontic therapy may not be needed. So fixed orthodontic therapy will only help in final occlusal adjustment if it was not achieved initially with the support phase and retention phase as well.
I think you answered another question which was following.
For anterior.
Asked, how many cases do we need fixed therapy after completion of twin block therapy? Is it always mandatory? Was the next question. I think you have answered that question also.
Yes.
One more question to you. Can you elaborate between twin block and the newly coming T4 appliances for class 2? The trainer for kids and trainer for appliances, the trainers. So they're asking you to elaborate the differences or how for class 2.
The first major difference is it's a monoblock appliance. The patient cannot talk, the patient cannot eat. With twin block appliance, it can be worn 24 hours, and it is indicated in Graeber also, it has been stated that it should be worn while eating also. Initially for few weeks, this child may not, because this occlusal function helps to trigger the muscle activity, and that brings the changes or the functional orthopedic changes which we want from twin block appliances.
Yeah. Thank you so much for answering all the questions. Actually, there is one more question just being repeated again. I think they want an answer from, you can answer that question. There's something called froggy design in band and loop. When is it indicated? What is froggy design in band and loop, and when is it indicated? It looked like an interesting question to us. So any of you, if you can.
So, Sharat, to my knowledge, there is, I'm personally not aware of a froggy design in band and loop, but there is something which is known as a froggy space maintainer, but it is not exactly a space maintainer. It is more like an expansion appliance, which is used only for maxillary molar distalization.
Maxillary molar distalization.
Maxillary permanent maxillary molar, first maxillary molar distalization it is used. So along with that, the appliance is something what we can say, it will look something like our the jack screws that we use for expansion appliances. So instead of it being on the horizontal side, the appliance is more on the vertical segment. And then it will have two wire components which will be going on either side. And then you will have the bands which are welded to the maxillary first molar with the buccal tube. So when along with the maxillary molar distalization, it can be very effective and it is used as a headgear. But in the band and loop, I'm actually not aware of that.
Okay.
I've not come across that terminology.
Okay. Yeah. Yeah. Thank you so much. Can we have Parimala ma'am to? Are you here, ma'am? Yes, ma'am. Yes, ma'am. Can you give a token of appreciation to our lovely speakers?
Definitely, it was wonderful session, and all knowledgeable ladies here and beautiful ladies. It was really great to have you all. I think the students really acquired a lot of knowledge in these particular topics, and it will be a great go for them. Thank you all, and
thank you so much. Thank you so much, ma'am. Thank you to ISPPD Head Office, President and Secretary, sir, and the host team.
Yeah. Can we have a certificate for the second speaker, Dr. Nupur? Actually, today we have lots of questions. All these questions are basically the questions asked in the department of the PGs. I think they typed everything.
But the session was really good.
Thank you so much, sir. Thank you so much, ma'am.
Token of appreciation to Dr. Anshula.
Thank you so much. Thank you, Parimala ma'am, for all the praises. Thank you, Dr. Sharath, Dr. Geeta Priya ma'am, everyone from Team KSR for organizing wonderful program, and all the delegates who were attending these 4-day sessions, and all the best everyone for your exam. Thank you, sir.
Thank you. Thank you so much. Can we have our all the speakers to present a token of appreciation to our moderator, Dr. Parimala ma'am?
Thank you so very much, all the speakers and my co-moderator, Dr. Radhika ma'am, and special thanks to Sharath Ashokan and his team. Really, they all really worked hard. Like, I mean, I can understand being the dean, what is going I go through, but yeah, spared the time for this. And thank you, Nikhil sir, and Osmi ma'am. Thank you so very much.
Thank you. Thank you, ma'am. We will also show our gratitude to Radhika ma'am. We will share the certificates. We will pass it on. Can we have the certificate for Radhika ma'am as well?
Yeah. So on behalf of Madam, I thank everyone.
Thank you,
so very much. It was really wonderful hearing all of you. Like first time I heard, I hear Anshula oftenly, but Dr. Vinola and Dr. What is
Nupur.
Nupur. Yeah, so sorry. So it was really nice to hear you. Thank you so very much.
We needed to definitely give them the platform, because ma'am is definitely a known speaker, renowned speaker. So we wanted to give it to our friends as well. So thank you for that. Was a great session. It was a great lecture listening.
Really, it was a great session.
Thank
you. Thank you, ladies. Thank you so much.
Thank you. Thank you so much.
This brings us to the end of.
Thank you so much.
Yes, ma'am. Yeah, this brings us to the end of session 7, and we'll all meet you for the valedictory as well. Session 8 and valedictory. The links will be shared to you soon. Thank you so much.
Thank you.
Thank you.
Bye all.
Bye. Bye. Thank
See
you.
you all in Bhopal.
Bye.
See you all in Bhopal. I'll take this opportunity to invite all of you. You know? So
Yes,
please do
ma'am,
come, all of you. It's a personal
definitely.
invitation. Yeah, I'll be calling you all again.
Yes, ma'am. Definitely.
Thank you so much.
Thank you, ma'am.
Thank you.
Thank you.
Bye.
Thank you, sir.
Thank you.